What are some of the different kinds of strategies and resources that you've integrated into your program to support survivors who use substances, or maybe who no longer use substances, are in recovery? So, kind of along that spectrum.
Absolutely. So we actually have on staff a certified addictions counselor, and she's been with us for about 10 years. She does groups and individual counseling services, and she's been, like I said, she's been with us for a really long time. And we actually at the shelter, and like I said, we have transitional housing, and so it's a little bit more difficult for her to be as effective in the community because people are in their homes. But at the shelter, she's so effective. Sometimes she's just sitting in the dining room and just chatting it up, having conversation, and it's just been really helpful. She's been helpful in a lot of ways that you wouldn't think that having someone on staff that is there to offer that very specialized treatment and very specialized understanding as well. And I'll give you again a couple examples. One thing that we know is that abusers will use the legal system, will use family court, will use many tactics to continue to abuse their exes or their spouses and so on. And one thing that we don't think about is that the court systems actually just want to know that you're trying to get help. And so what's been helpful for us even is the CAC, the addictions counselor, being able to say to courts or to write a testament to this person doing their best to get on the right foot. And so that's been really helpful. We've had folks kind of run into issues around custody. So having a CAC on staff is just really helpful because she can provide intervention in different ways. Just as you were asking, what if there's someone who's trying to maintain their recovery? But there's also something to be said about having an addictions counselor. That's a very specialized work. It is not always the most trauma informed, is what I have found. I've attended many AA and NA meetings with friends, and I've noticed that in those groups and in that model, it's that peer model is a bit different. You talk to your peers a bit different than you would talk to a coach, a family member, a clergyman. It's just something much different. And what I have found is there are things that maybe a case manager or a counselor cannot say or wouldn't be appropriate to say, whereas someone who specializes in addiction can kind of say, hey, I've seen this before. I know what you're up to. I know what's going on here. And let's have a very serious conversation. I remember the first time we had a client that was just really struggling with addiction, or at least in my experience, I should say. And I remember thinking, well, I don't know what's appropriate to say. I don't want to be accusatory. I'm not the professional here to say that these are the signs and symptoms of your addiction and so on and so forth. And so in having an addictions counselor who that's their work and their job to do that, it's just nice to have that support. And I also have found that clients have found that it's nice to have a person who gets it and who gets you in that way, because there is a lot of stigma and a lot of shame around substance use and substance abuse. I'll use that word as well. Whereas those counselors often really understand where it's coming from and also understand the physiology of it as well. That sometimes it's beyond what you can control, and they can guide us through those processes. So it's been really helpful having a specialist on staff that can help on both sides, both the team manage, and there's times where she'll advise and say, this might not be the best program for this person because this person might need detox, or this person might need a bit more of a restrictive environment because they are trying to get clean, but the temptation is there, the neighborhood's there, their peers who are also using aren't a good fit for them right now as they're trying to get clean. All of those are things that kind of that voluntary services, trauma-informed care doesn't always match up with. And I'd rather say that out loud than to pretend like harm reduction and trauma-informed care always align with someone who needs something different. And that's why it can't be everything to everyone, but it's open for discussion and having that really great, honest conversation. And so the other part is that we partner with other organizations for when we do have something that's not within our skill set, not within what we have at our program to be able to assist with. We've had another common substance in this area is PCP. And so that can have very many different effects on people. And so we've been able to warm transfer people to other programs so that way they and their children are safely placed. We know we even keep communication to make sure that when they, are done with treatment, that they are able to, be in touch with their children and things as such. It's just been really, I think the community is doing so much better in our area as well around that, around understanding that you can make things worse when you kind of debunk someone's life over something that they're just looking again to get help. They're here with us. And that cry for help doesn't mean that you stand back and watch. You jump in and you help. And so that's been really great with partnering with other substance use organizations, whether it be for acute treatment or whether it be for long-term permanent supportive help.
Yeah. And so, how did you get started with identifying and cultivating those relationships with those substance use providers?
That's a really great question. It's not my wheelhouse. And so we have relied on our CAC to give us the lay of the land, to help us know. And also, we have in the district a few collaborative communities, if you will. And so one thing that we're a part of is the Victim Assistance Network. And that has been a really great place to have multidisciplinary teams there telling us where we can go, different presentations around what's available. And so that's been very helpful. And then also just getting out there and, believe it or not, asking our clients, because there are plenty of clients who have like, I don't want to go there. This place is not great for me, or that neighborhood where this place is not great for me. There's just, sometimes it's collaborating, not sometimes, actually, I believe that wholeheartedly that you should collaborate with the survivor more than anyone else. And oftentimes those who use substances, this isn't their first rodeo, it's not their first go at it. And so they'll often say, this program didn't work for me, or I like this program, I want to go here. And then there's also someone who's like, I just want to go back home. And that's okay. And so what we do is we talk about, are there other, let's see what's your local AA or NA, or let's see if we can, I'll go with you. We've had some really great experiences with that as well, especially if it's a first time. But our CAC will do that too. She'll take people to their first meeting, or apparently there's Zoom meetings now. So that's been really cool. Yeah, I mean, I think the more you reach out, we have found that communities, once they get to know your name and the gatekeepers of those communities, they'll reach in as well. And they'll come to us and say, hi, we started this new program, or we have this support group, or we're starting something at the library. And then we pass it on to our clients. So it's a combo of getting out there, but also people coming to us. It's been great.
It sounds like once you form those initial contacts and relationships, that things become a lot easier from there. And that, your kind of in-house substance use specialist is a huge resource. And then also talking with the survivors themselves, that a lot of times they know best the landscape and what is going to work and what isn't going to work for them.
Yeah, a lot of the people that we serve are Native Washingtonians. And so they know it's in the area. They know more than most of us who are typically transient and not from the area. And it's been, I would say, very helpful, where, I mean, we've even had someone say, oh, please don't send anybody there. This thing happens. Or, it's kind of silly to send them there, because as soon as they walk out the door, there's going to be somebody standing out the door waiting to offer them this, that, and the other, or it's not good to send, talking about culturally specific, it's not good to send someone to this area, because that area is, heavily populated with people of their culture. And there's a lot of stigma, and they probably don't want to go there because of, fear of being seen, fear of being outed around what they're going through. So it's, again, listening, keeping your how they say, your ear to the ground and hearing what's happening and keeping yourself informed. Don't make assumptions. If someone's resistant to going somewhere, it's okay to maybe ask them why and see if you can come up with an alternative. I think that's something that we've done much better about, that we don't take it as someone rejecting our services or rejecting our suggestion. It's about asking how you can better assist them then.
Yes. So often it's so helpful to come up with like a follow-up question or to remain open
Yeah,
and not, again, coming back to that, not making assumptions, not assuming that that's just because someone doesn't want to, that people have reasons,
yeah,
right? And so
exactly.
remaining curious.
Yeah, I mean, I'll give you the example, or not an example, but the scenario is a majority of treatment centers are in Southeast DC, and a lot of our clients come from Southeast DC. And so the issue with that is you're going back, there's a lot of risk. You're going, maybe you're compromising safety, maybe you're compromising sobriety. Um, Maybe it's just traumatic to go back to the place where you were abused or the place that you grew up or the place where your addiction started. I mean, there's so many reasons. That's one of the big kind of conversations is, putting resources where the help is needed, but then also, are you just compressing and pressure cooking the whole situation by putting everything in one place and as opposed to a place to escape? So again, don't make the assumption. Just ask the question. Ask the question, and the worst you might hear is, "I don't want to talk to you about it," and
Mhm.
and you have to respect that. You really do.
Yes. And everything you've shared, I'm really hearing that balance between offering resources and support and still remaining voluntary services, low barrier, and really survivor centered.
Yep.
And so what are some other ways that you and your staff and you help your staff really kind of hold that balance?
Absolutely. It was trickier in the beginning when we were changing, if you will, when we were transforming than it is now. Now it's simply, I can just say something as simple as, consider this. You get to go home to your bed that you know will be there, and you know everything that you need is right where you need it and where you left it. Consider what this person is doing. They're coming to an unknown space with unknown people for an unknown time and an unknown result. That's usually very grounding. It's usually very much a space of, you don't even have to put yourself in a person's shoes. It's more, consider the privilege that you have and how it's easier for you to say that than it is for that person to do that thing. And so we are huge on compassion, but rational compassion. And that's something that I learned from a psychologist a long time ago that was doing some training for us. He's just like, we talk about empathy, but you need to be rational with that empathy. You need to be rational with your compassion. Remember what your task and what your job is. Your job at that time is to help that person and consider how much you're helping. And so being compassionate, but being honest. I think it's also really important from the beginning to be honest about what we have to offer. That's always important. Being honest about what you're observing and what you might be thinking. I think that instead of making those assumptions, I think it's better, like I said, to ask. And that asking is also part of being honest. And then also offering choice, right? We talk about motivational interviewing, and we talk about talking about, there's plenty of times where we've had clients, say, like, I just don't think I'm sick. This is not a good program for me. And we say that that's a really honest. And I think, well, let's talk about what are some of the choices? What are some of the options that we have now? What are some of the options that we might have to wait on because there's nothing available? Offering, and I shouldn't say offering choice, because you're not offering the choice. If I were to be nitpicky about language, it's more about presenting the choices, presenting the options, so that way a person can make an educated decision or make a decision that's best for them. And so with that, it takes the onus, because that's part of what we've seen, is that in the field, we tend to take a lot of responsibility and accountability that it's my job to save a person. But that's not your role. Your role is to empower. Your role is to present options, is to refer, and to know your limitations. And that's something that we really advocate about. We always hear self-care, 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 but we don't practice it well. And I often tell people, if you've kind of reached your limit, if you're above your baseline and you're not in a great space to help a person, if your implicit bias, if your thoughts about a person or about a person's decisions are affecting the way that you're providing quality care, then take a day off, take a couple days off, go on vacation, or whatever your ritual is that you need to do to recenter yourself to provide quality care. Substance use, well, just even poverty in general, to be fair, and domestic violence, especially knowing that a person's trust has been completely broken and you're expecting them to trust you as a stranger to tell a person what to do. Like, none of that makes sense when you say it out loud. And so that's a big thing. And we have staff meetings every week. And we don't necessarily talk about everything every week, but when I notice that there's like I call it the pressure cooker kind of feeling where you're just like, something's bound to happen any moment, we just talk about it. We talk about what we're seeing, what we're feeling, and we talk about strategies to help us get back. And sometimes it's talking about the narratives about what we're seeing and dissecting it a bit to say, well, why do you think that might be happening? And that's where you can reinvigorate your compassion, which then reinvigorates your want to help. And so that's how we create that balance. And then sometimes you might have, and that happens in this field, that burnout, where it's hard for you to get that compassion to stay. But in the time that I've been there, we haven't had that happen very often. So that's been great, just keeping that balance going.